Good morning. Welcome to our electrocardiogram physiology. So this is a test that records the electrical activity of the heart over a period of time using some electrode that is normally placed on the skin. It is preferred because it is a quick, non-invasive way to detect and monitor many heart conditions. So this includes various types of bradycardia, various types of tachycardia, and you can also be able to map the regularity of the heart rate. And it is from that we are able to diagnose some of the very important heart conditions. So before we sink into this, it is very important for us to remind ourselves of the cardiac cycle. Where we suggested that cardiac cycle represents the events that normally happen from one heartbeat to the next heartbeat. So more obviously for us as clinicians, that is mostly auscultated by a stethoscope, so whereby you are able to elicit S1 and S2. So when you are hearing an heart sound or an heartbeat, it is actually composed of two heart sounds. So that is the S1 and the S2. So whereby the S1 will be a representation of the ventricular contraction. So as you can see in our image over here, so when the ventricles contracts, the atrioventricular nodes are normally close or normally closest. So these are the atrioventricular valves. So as we contract, as the ventricles, these valves close, and this is responsible for the sounds that we are likely to hear as the S1 sounds. So the closing of the atrioventricular valve. So this will be representing the ventricular systole. And the S2 is a representation of the ventricular relaxation. So as the ventricle relax, the semilunar valves will actually close. This is because when we relax, the pressure inside the ventricle reduces, and the pressure at the trunk or the aorta is able to force these semilunar valves actually to close, and in the process we are able to hear another sound by the name S2. So that means that using a stethoscope you can be able to appreciate a cardiac cycle by way of focusing mostly on the sounds. But an alternative way of also representing a cardiac cycle will also be through an ECG. So whereby with an ECG we are focusing more on the electrical events that are taking place in the cardiac muscles, or rather in the heart. Let's just say in the heart. This is because by the time we are having our atrium contracting, our ventricle contractings, they are doing so because we can say that they are electrically charged. So there's some form of energy that is being used by these muscles to contract. So when it comes to something like the ECG, our main question is actually to try and trace how this electrical energy is being generated and how does it spread. So how it's being generated and how it's spreading from the sinoatrial node up to the very last point of the cardiac muscles can be well represented in the ECG. And of course, the movement of electrical impulse from the sinoatrial node and eventually into this distal cardiac muscle can also be a representation of an electrical activity that takes place between one heartbeat to another. So this is just an alternative that is likely to give us more clarity, especially when it comes to matters of the heart rate, pulse rate, where you are able to talk more about the regularity or the irregularities, and of course in the process we are also able to come up with some disease process. So for example, somebody will say if this is a muscle of the of course, the ventricle. So if there is some form of infarction, so infarction, that means that this place is actually consisting of necrotic tissue, means that it might not be able to propagate electrical signal appropriately. So ECG can also be able to detect such errors, and that's why it is actually very important when it comes to matter of diagnosing some of these medical conditions. So to be more precisely, having that now we are talking about the electrophysiology, specifically with the cardiac. So our focus will be with the muscles and also with the conductive system. So for example, if you were to take a single point of the muscle, this is what we'll end up with: a sheet, meaning that these are you can talk of the cardio myocyte. So these are specific muscular cells, and we can see the way they are tightly packed. They are closely arranged with some form of some gap junctions over here. So this is very important electrically, in that when these muscles, or rather this myocyte, is electrically activated, the impulse is likely or is able to move with ease because of this tight gap junction. So that if this area is stimulated, it will contract. And because of these tight junctions, the movement of electrical impulse normally happens in a very speedy way, or in a very smooth way, so that it will seem as though the whole sheet of muscle is just contracting as a unit. So the contraction as a unit is possible because of these gap junctions that allows easy movement of electrical impulse, or we will say some ions, as we'll realize much in our discussion. So if you are to expand one of these myocytes, so this is what you will be expected to have. So this is actually one of the myocytes that has been expanded. So you can look at intracellularly what you can expect. So maybe the most important thing for us to note is these transverse tubules, and also this myofibril, or we can talk of the contractile units. So that means within one muscle cell, or within one cardiomyocyte, we should be having a specialized arrangement of the myosin and actin. So in that we are covering the ECG, what we are insinuating is the muscle is only able to contract as a result of the electrical energy. So for us, we'll just be exploring how will the muscle, or rather how will the heart generate this electrical energy, and how will this electrical energy be propagated through the rest of the muscle, so that we are able to see the heart contracting as a unit. By unit, we mean the atrium contracting in unison, and the ventricular muscle also contracting in unison. So if you are to expand this further, this is what you'll end up with. So this representing a cardiomyocyte cell intracellularly, what you are expecting to, or what you anticipate. But this is more specifically relating to some of the important ions that are expected to be very important in the contraction and the relaxation. So before we explore whatever is taking place in this particular image, so let's just remind ourselves of some action potential and some resting potential. So when it say a resting potential, what does it mean to a particular cell? So let's just write it here a little bit. Resting potential. So this is a state. This is a state in a cell where it is not, we'll say it is not electrically active. It is not electrically active. And when you translate this to cardiac muscle, this represents some relaxation. And we can have some active or some action potentials. So this represents a cellular state where the cell is electrically active, in that it can allow electrical impulse to move from one cell to another. So if you translate this grossly to a cardiac muscle, this will be a representation of some contractions. So that means that a cell, or rather a cardiomyocyte, should be able to shift from relaxation to contraction, contraction to relaxation, in that we know that the heart should not be just be contracting in a sustained way. So it should be it should be able to achieve some contraction, it relax, it contracts, relax, contract, and that's what makes the heart beat. So it will be very important for us to explore how maybe you move from a resting potential to an action potential, and how you move from an action potential to a resting potential. So for example, another term, when you're moving from a resting potential, when that is of course in relation to a cell, from a resting potential to an active potential or an action, will be say that the cell is being depolarized. Depolarization. So this is depolarization. When the cell is transitioning from the resting phase into an action potential, this is depolarization. A cell can also transition from an action potential to a resting potential. So this is called the repolarization. So this is only possible, of course, if you are able to remember some of the specific basic attributes of a cell membrane. So whereby we say that a cell membrane sometimes can be considered as a conductive or electrically conductive unit. And how is it able to achieve this? This is because the cell membrane I'll not say easy or just free movement, but I'll say movement of some ions, of some very important ions that detects or dictates the electrical state of the cell. So these ions could be majorly sodium. We have the calcium. We have the potassium. And we also have the chloride, very important. So in that, somebody will say that A cell could be when you are having excessive entry. This is just by with an example. When you are having maybe excessive entry of sodium into the cell will accumulate more sodium, so meaning that sodium are normally positively charged, so the cell will be more positive. So you'll say that this cell is actually positively charged. You are able to say that because we are having excessive accumulation of positive ions or cations. So one of them could be sodium. Of course, you could also be having something like calcium. When there are some factors maybe within the cells or within the cell membrane that allows maybe massive entry or retention of some ions such as chloride, and we have excessive accumulation of it, it means that the cell will be much negative. And we'll say that this cell is negatively charged. So the electrical state, the way you are seeing so far, can be dependent on the distribution of these ions. Which ions does the cell has in great quantity? Are they negative ions? Are they positive ions? So that is likely to influence the charge of the cell. And we are saying that is possible because of the cell membrane. The cell membrane should be having some specific channels that allows these ions to either enter or exit. So ions are very important in determining the electrical state of the cell. And of course the cell membrane, because the cell membrane possesses the specialized gates that allows for the entry and exit of these ions. So let's go back to our resting phase. This is because we are acknowledging that before a muscle actually contracts, it needs to get from a state of relaxation so that it contracts. So in a state of relaxation, we've been able to represent that to, or attribute that to a resting potential. So your muscle is relaxed because it is not electrically charged. This is because it is resting. So ordinarily in a normal resting cell, how does the cell normally looks like? So for example, not an example, so I'll just go straight and illustrate the resting state of a cell. So this is what normally happens. So consider you are having your normal cell. So I'll just draw a sketch of it. One of the important elements in every cell or in most cells in the body are normally the sodium potassium ATPase. So these are pumps that are normally in most cells or in many cells. So let's write this as sodium potassium ATPase. So that normally pumps sodium out. So this is what happens normally, and pumps potassium in. So this is a type of active transport. And remember what we said with active transport. Active transport, ions or substance or solids are moving without much regard to the concentration gradient. So sodium potassium ATPase, so let's write it here. This is sodium potassium ATPase. So just to remind us, so this is a chemical related gate that normally breaks down the ATP so that we are able to get the energy to move sodium out and to move potassium in. So this will just be ongoing. Even if you'll be having excessive concentration of sodium outside, this process will just be ongoing because it does not, it uses energy and not the concentration gradient. So ordinarily what happens in the sodium potassium ATPase pump, we are able to pump out sodium, and at the same time we are able to take in potassium using a similar, the same pump, sodium potassium ATPase. So this pump is normally specialized in that you normally extrude three sodium, and you normally admit 2 potassium. And also, before we expand more on that, onto what consequent will the cell have electrically. So let's also acknowledge some of the channels. So we can also have some other channels. So this is let's say the sodium channels, and we can also have a channel. So let's say that these are potassium channel. So let's the story begin from this side. So we say that in an ordinary time, when the cell is resting, or even when the cell is not resting, the active transport will always be there. So meaning that we'll be extruding sodium out and we'll be admitting potassium in. So in the process, what you are seeing is we are taking out 3 positive and we are taking in 2 positive. So if you take the net difference, we are likely to be losing 1 positive, because if you give out 3 and take out 2, you'll say that you've lost out 1. So in the process, what happens? Our cell is likely to be much more and more negative as this exchange over here is ongoing, because for every single exchange we are losing positives, and every time you're losing positive, will be remaining with negative. So think of negative as maybe some ions that are not necessarily getting out of the cell. Think of the negative as maybe the amino acids, or maybe majorly proteins, which are normally negatively charged. So the cell is likely to become much negative with time. And of course, as we are moving our sodium out, it means that inside the cells, the number of sodium reduces. So let's write this as a concentrational gradient. The number of sodium actually reduces. So when the number of sodium reduces, this favors the movement of sodium from the extracellular into the cell towards the concentration, of course respecting the concentration gradient, assuming that we are having more concentration of the sodium outside. Of course that is true because we are pumping a lot outside, so we are able to gain some through some form of we'll say passive transport or facilitated diffusion. It is facilitated because it is not just simple, it is using some sodium channel. So it is being facilitated by some sodium channel. So this explains the movement of the sodium. So this is what is happening at the resting state of the cell. You need to remember that. While continuously through the active transport, remember we are admitting 2 potassium. So that means after a duration of time, the concentrational gradient of the potassium, the concentration of the potassium inside the cell is likely to increase. And this will favor the movement of the potassium outside. So remember, from a region of high concentration to a region of low concentration. Also with the sodium, from a region of high concentration to that of low concentration. So this is what normally happens in the resting state of the cells or the resting potential. And it is good to note this. When the cell is resting, you can actually see the type of charge that it will be possessing. So for example, we've been able to see that when the cell is resting, it will be having some negative charge, or it will be, say, negatively charged. So on to our key here, where we say the resting potential representing a relaxation. Electrically, somebody will say that this represents some negative charge. So having that, now we've now maybe explored the resting state. So how are we able to shift from the resting state into an action potential? So that is the process where we've agreed that we are referring it to the depolarization. So for example, think of this as a cardiac muscle cell that is resting, and how now does it transition from resting into an action state? So maybe under some neuronal stimulation, some chemical stimulation, so this can apply to any electrical cell, and appropriate stimulation, we'll see our cell transitioning from the resting state into action state. So what is specifically happening? So in the depolarization state, we are shifting from the resting into an action potential. What is happening specifically is with the sodium gates and also the potassium gate. So let's just have a repetition of this and see what is happening. So we can still have our sodium potassium ATPase pump constantly removing sodium and admitting potassium. The depolarization state, the permeability of the cells to sodium normally increases. So for example, under some neuronal stimulus, under some chemical stimulus, the rate with which a cell is likely to take in sodium will increase. So that means the cell will take more and more sodium than the normal. So you can say that in the depolarization, the permeability of the sodium normally increases. So that means the cell is able to take a lot of sodium than in the resting phase. So this representing the depolarization state. And what is happening to the potassium gate? The permeability of the potassium is reducing. So while we are having the permeability of sodium increasing, in the depolarization, the permeability of potassium ions reduces. So that means the number of potassium leaving the cells is actually reducing. So what does this mean? This means that our cell, which was previously negatively charged in the resting state, if our cell actually absorbs or takes in a lot of sodium, which are normally positively charged, it means that our negative will be reducing. So they will be having some form of transition from negative towards the positive, because we are taking in more sodium. And again, remember, because we've reduced the rate with which the potassium is leaving the cells, that means we are also retaining more potassium. which again are positively charged. They are positively charged. So if you are to have some graphical representation, so let's just have a little bit of this. If you are to have some graphical representation, where we've said that the resting state, let's put this as the rest, it's on the negative side, and as you move up, you will be going towards the positive. That means the action or the active state. So as we are retaining more sodium, as we are retaining more potassium, and as we are absorbing more sodium, our cell will be shifting from negative towards the positive. So for example, so this is just an example. So for example, in the resting phase of the cardiac muscle is normally at around -80. So -80. So as you retain more potassium, as you absorb more sodium, we will move up the ladder. So we'll be transitioning from -80, so maybe let's say -60, -40, -20, maybe 0. Let's be generous a little bit, +10, and let's say up to +20. So we are likely to have a graph moving with something like this. So this becoming our explanation. We are moving from the resting state into an action state. That meaning we are moving from negative into positive. So that this now represents some action potential. Action potential state. So back to our key. Action potential was representing contraction, and electrically you can say that your cell is positively charged. And remember, when you're saying positively charged, it doesn't need to be an absolute positive. For example, if you move from -80 to somewhere like -40, you say that -40 of course is more positive than -80. At least you've been able to reduce the negativity. So this transitioning is what we are referring to as depolarization. While if you revert back, this could be termed as repolarization. So before we explain what happens specifically in the cardiomyocyte, we've said that you're transitioning from the resting phase into the action state. This is the depolarization. And you are transitioning back into now the resting. This will become the repolarization. So maybe to put it into context before maybe we explore what is taking place specifically with the cardiomyocyte. So how do we transition from a state of action potential into a resting potential, at least using these ions? So in a repolarization state, what happens? So let's just write it here. Repolarization, what happens? The permeability of sodium reduces. So this means the amount of sodium gaining entry it's able to reduce. So if this reduces, it means that the number of positive will also reduce. This is because remember, our active transport is still constant. Only that what was taking place in the action potential, the number of sodium entering were too many that it overwhelms the active transport, in that in as much as the active transport is extruding out 3 sodium, it is not able to match the number of sodium that is coming in. So that means that the cell will be much positive. But when this permeability reduces, it means that our normal sodium potassium ATPase will be able to extrude out sodium, and eventually we'll have our cell returning back to negative because we are able to expel the sodium that accumulated during the action potential. So in the repolarization, the permeability of sodium reduces, while the permeability of potassium will actually increase. So this means the number of potassium getting out of the cells increases greatly to match what ordinarily looks in the resting phase. So that means while we are letting our potassium to get out, our cell is returning back to the negative state. Because you lose potassium, you take away the positivity. So this is what happens. So when we say we are shifting from an action potential, we can actually appreciate this to specific electrical or rather the movement of these ions that are of very, very important. So what happens specifically when it comes to cardiomyocyte? What you need to know with the cardiomyocyte or with the cardiac cells, their action potentials, of course, we are having a say by the sodium ions, but you also need to add an ion like calcium, which again is positively charged. So what is the story when it comes to the cardiac muscles? So this is the resting phase, as we suggested. So what will happen in the cardiac cell? So this is what will happen. So let's just draw it grossly. We redraw our action, not action, but some sodium potassium ATPase. Sodium, so extruding 3, admitting 2 potassium. The cardiac cells very unique, so they'll still have the sodium gate. They still have the potassium channels or gates, and for convenient or for matter of space, let's write just calcium here. So they also have some calcium channel or gates. So maybe as a reminder, what you need to know about the calcium channels. So these are normally voltage dependent gates. So that means they open and close depending on the voltage of the membrane. So for example, as a matter of fact, when the voltage of the membrane is at -40, they'll open. When it is lower than that, they'll close. So another thing that we need to know, we've said that they are voltage dependent gates. These calcium channels are also slow to open and also slow to close. So we've said that when a cell transitions from a resting into an action potential, electrically you are saying that you are moving from a negative into a positive. So the positivity of the heart, the cardiac cells, is majorly attributed to sodium, potassium, and calcium. So this is how the story goes. So in our resting state, the cell was negative. at least we are able to know why the cell is negative. We've said that anytime you are extruding 3 sodium out and admitting 2 potassium in, it is just like you are losing 1 positive. And eventually, if this movement of these are just constant, our cell will become much negative and negative and negative. So unless we reset it by the action potential that normally occurs. So the same circumstances, so maybe let's say under some neuronal stimulants, under some neuronal stimulation, chemical stimulation, physical stimulation, whichever stimulation, the permeability of the sodium will change in that it will increase, so that it allows a lot of sodium to enter. And the permeability of the potassium will increase in that the number of potassium leaving reduces, the number of sodium entering increases. So if you are to put a graph, we say that in a resting state, it is normally represented by some negatives, so let's say at negative 80. And of course, we are having, let's put positive 20 as the most active state. So let's put a graph. This is a y-axis representing some voltage. Let's choose some millivolts, will be much appropriate. And x-axis, a representation of time, can say second, a millisecond will be much appropriate. But no, just know this is a representation of time. So as we are having, as the wave of depolarization comes, where we are increasing the permeability of sodium and reducing the permeability of potassium, so we'll be having our cell actually moving towards the positive because it is being positively charged. So we have some negative 60, as we complete, negative 40, negative 20, let's say 0, and then 20, so that one is much fair. So let's put it. So what normally happens, so as sodium is entering, as we are limiting the amount of potassium that is leaving the cell, our cell becomes more and more positive. So that means it is moving from negative 80, climbing the ladder, as we are able to see. And what you have to note, we say that calcium channels are normally voltage dependent. So that means that as sodium are gaining access at around negative 40, this electrical state or voltage will be much appropriate for the calcium channels. So the calcium channels will open. So as the calcium channels opens in a very slow fashion, it will allow massive entry of calcium. So as calcium is gaining access into the cell, I remember our cell is likely to become more and more positive. So let's exaggerate and put everything positive. So it's becoming more and more positive. And if you follow your graph, so this is what is happening. So this is unique with the cardiac cells, and maybe some skeletal muscles, and also some smooth muscles, that normally their contraction is as a result of entry of the calcium. So where maybe will be at 0, maybe up to 20. So this is marked by entry of calcium. And remember, we've said that these calcium channels are normally slow to open and slow to close. So that means we are likely to have some sustained positivity. So this is likely to give us what we can call here as a plateau, or some plane in a high amplitude or in a high altitude, but amplitude in matter of graphs. So this marking the entry of we are having the entry of calcium, and we are retaining it because once the rate, or rather the wave of depolarization, does not normally stay for long. So let's say we've had the entry of sodium, calcium, limiting the exit of potassium. So this will be followed by the repolarization wave. So in the repolarization wave comes, the entry of sodium reduces obviously, and the exit of potassium actually increases. And we'll explain ourselves that we also have an alternative pump that can actually allow potassium to get out while allowing sodium to get in. So in the process, we are the cell will be losing the potassium, and also be losing the sodium, and increasing the amount of calcium, rather potassium, that is exiting. So this will be representing some repolarization. So the cell is somehow attempting to come or to go back into the factory setting. It is the rate of depolarization. So remember, this is just a graph that represents a single electrical event that is happening to a cell, and not really an ECG graph, where we say that ECG graph actually now maps the movement of action potential. How is it shifting from one cell to from one chamber, and we'll be able to see that. So in a single cell, it can be electrically represented in a graph like this, or graphically represented like this. The electrical events within a particular cell can be represented like this. Action, resting potential, entry of sodium up to a certain level of -40, where we are likely to have massive of calcium, meaning that our cell will even become much positive. We are likely to be more positive for quite some time, because the calcium channel normally slow to close. So unlike in cells where do not have the calcium channels, maybe where they don't play a major role, maybe you can have something like this. Because the sodium channels and the potassium channels, they normally open faster and close faster. So if you have the peak of an action potential, you just have something like this, rather than a plateau. The plateau meaning that the calcium, while we are having the rate, the wave of repolarization, sodium changing very quickly, in that it doesn't allow further entry of sodium. This changing very quickly, in that it allows massive exit of potassium. The calcium just delays, so that in its delays we'll still be having entry of calcium. So meaning that we'll still be sustaining our action potential at a plateau level until where it is now closed. That's when now you anticipate it to go back to the factory setting. So this can be a plateau. This becomes the depolarization, because you are moving up, and this is the movement, and we are moving down. So this is the repolarization. And if you extrude this a little bit, so let's extrude this. If you extrude this, not so straight, but let's assume it's straight. So this will be representing the refractory period. So this is a period where an action potential is not possible. So the cell need to rest for some milliseconds before a wave of depolarization, so that you have something like this. So let me find some space so that you have something like this. Just a minute, let's delete this. So this is what you might end up with in a normal cell. So let's have our y-axis and let's extend our x-axis and let it continue. So you'll be having something like this in the cardiac polarization. Then and then it will be ongoing. So maybe to give us a clue as we continue, so we can say that when you are using electrocardiogram, or when you be using electrocardiogram, because the action potential is actually dependent on this, on the movement of sodium, potassium and calcium. So that means if you have some electrical or some electrolyte imbalance or some biochemical imbalance, they might also affect the way the ECG will be displaying their results. So that is very, very important to note. So back into our cardiac cell, what we had here. So in summary, so this representing an action potential, or rather a wave of depolarization. So that means that when there are some changes in the cells that favors depolarization, so that means we are having sodium entering, we are limiting the exit of the potassium, will be represented like this. So when this wave comes, it will affect the calcium channels, so they'll open -40. When they open, calcium gets into the cell, and of course the action as it becomes more positive. So we also have some sarcoplasmic reticulum. So these are cellular intrinsic storage mechanism for calcium. So this also opens. So when they open, we are likely to have a lot, an increased number of calcium within the cell, and therefore a cell becomes more positive. So the actual contraction is actually experienced by the action of the myosin and the actin. So we have a very important biochemical by the name troponin. So troponin, actually depending on the calcium, so it has some binding site for calcium, think troponin C. So once it binds to the calcium, it is able to present the calcium to the actin and the myosin, where they'll be able to activate some protein kinases. This calcium can activate some protein kinases that allows the myosin and actin to contract. So the actual contraction that we are seeing is by the calcium. This is because calcium has the ability to activate some very important enzymes that can assist in the contraction. And what is presenting calcium to this contracted unit? The troponin. So this will become the contraction. So what happens during the relaxation? Of course, we need to reduce the amount of calcium. So if the amount of calcium reduces, it means that the cells will not be able to contract, or the myosin actin will not be able to contract. So which mechanisms exist in the cells to get rid of the calcium? So that means returning back calcium to their intrinsic cellular storage area. So that is the sarcoplasmic reticulum. So So at the sarcoplasmic reticulum, we normally have the calcium ATPase. So that means it is able to use some ATP or some chemical energy to allow the calcium to move from outside into the inside state. So this is an active transport. Even if you are having extreme concentration of calcium inside, this will still be able to move calcium inside the store. So we have the calcium ATPase. So you need to note that calcium ATPase within the sarcoplasmic reticulum. And on the cellular membrane, because we are having entry of extracellular calcium and the intrinsic that is stored in this particular area. So we've had some returning, and we need to have others getting out. And remember, when it is getting out, our slow to open and to close calcium channels have closed. So we are having this from the sarcoplasmic reticulum closed, and we are having this of the extracellular, or rather the cell membrane, closing. So we are not having entry. So the good thing is that the same channels will not allow the calcium to exit. So once they are just open, the calcium may just force entry rather than exiting. So on the cell membrane, we have what we can call the calcium sodium exchanger. So this respects the law of diffusion. But it is just focusing on one ion. So this is what you can term as some of the, of course, the secondary active transport. It is indirectly using some energy derived from the sodium potassium ATPase. How is this so? So when you are having a normal sodium potassium ATPase, you are able to extrude a lot of sodium, as we suggested, out and admit more potassium. So in the process, inward will be having low concentration of sodium, and this will favor sodium to move inward by some form of diffusion. So from a region of high concentration to a region of low concentration. And remember, this is a specialized channel in that for sodium to move inward, it requires a number of calcium to be exchanged. So the sodium will not move in unless we are having some calcium. So remember, we still have some other, this is not to say that we do not have the single sodium channels as we suggested, and the single potassium, so whereby in again using diffusion. But all that, this has a condition. For sodium to move in, calcium needs to move out, and in the process we are getting rid of calcium. A reminder, it is a secondary active transport in that it is using the concentrational gradient of sodium that has been generated by this primary active transport. So that represents what will be taking place from one cell, of course, from one cell, and these events are expected to spread from one cell to another. So whereby in the heart we say that maybe an action potential starting in the sinoatrial node, spreading into the atrium, and of course it cannot spread directly into the ventricles. It will need to pass through the atrioventricular node. So this is an action potential spreading to the atrioventricular node, spreading through the his, through the bundles, and further demarcations into the Purkinje system, so that we are spreading the action potential from the sinoatrial node. We anticipate that majority of it starts from this area, so that it's spread to the rest of the heart. So when you are mapping the movement of this action potential from one spot into another, so this is what can be represented in our ECG by the what we'll be able to see, the P wave, the Q, R, S, and then the T wave. So this becomes the ECG. We are mapping an individual action potential that is starting from this area. How is it spreading in the heart? So this is what we are able to map in our ECG. So having that, we've had that introduction. So let's go to our second part now, more specifically with the ECG.